So, um, thanks all for joining. I we're going to talk about respiratory failure. It's a pretty complicated topic that I tried to kind of simplify down a little bit. And we're going to chat a little bit about the implications of it. Um, Real quickly, let's talk about a case. Something that I feel like happened frequently when I was in Tanzania at Saliani. Patient presents to be shortness of breath, and this isn't a particular case, but this is something that I remember happening maybe multiple times. They're noted to be altered. An astute clinician notices that they have asterisk, and that their SpO2 is 65%. Um, they have a history of cancer, and recently they've lost weight. The patient is um, ill appearing, gets admitted to the ICU, and starts to become more altered, subsequently develops a lower respiratory drive, and over the course of maybe an hour, ends up dying. They're given antibiotics for concern for infection, but the patient subsequently passes with family at the bedside. Um, and this is a individual case. There's not necessarily any diagnostic uncertainty. The patient likely died from hypercapnic respiratory failure. We'll talk a little bit about kind of why it was important maybe to evaluate for this and come up with an answer about what might be going on and what testing we could offer to the family. When we're talking about learning objectives, specifically for understanding the types of respiratory failure, but also understanding the distinction between respiratory failure and respiratory distress. Something that's very important in pediatrics. We'll talk about how that is also important in adults. We'll also talk about what causes respiratory failure. We'll talk quite a bit about end organ failure. The reason why is because respiratory failure is a type of end organ damage, and end organ failure, and it's important to distinguish whether or not it's occurring secondary to other types of end organ damage. And so we'll talk a little bit about that. We talked a little bit about a type of end organ failure last month, specifically about encephalopathy. If you want to reference that, it is also a type of end organ damage. It's kind of worth maybe reviewing if you're a little bit unfamiliar with the topic, but we'll talk enough about it today that hopefully you feel a little bit more comfortable about what it actually means and why it's an important thing to test for. Um, we'll talk a little bit about chest X-rays. We've had previous talks about chest X-rays as well, and we'll talk a little bit more about venous blood gas. We'll talk about ventilation, specifically mechanical ventilation as well as positive pressure. The reason why we want to talk a little bit more about ventilation is that I know that oxygenation is readily available in Tanzania, but ventilation requires a little bit. Um, it requires a little bit more. A little bit more specific mechanics in terms of implementing the um, actual intervention. It's not as simple as putting a nasal cannula on. So we'll talk a little bit about that. So, respiratory failure is defined as two separate entities. It's an inability to oxygenate or it's an inability to ventilate. The inability to ventilate requires basically retention of CO2. This is a specific type of respiratory failure, also known as hypercapnic respiratory failure. When you can't oxygenate, it's called hypoxemic respiratory failure. One thing that I'm going to introduce to you guys is that there are also two types. Type 1 respiratory failure, which means hypoxemic respiratory failure. Type 2 is hypercapnic respiratory failure. There's a presumption that if you ever have type 2, the reason why we would call it type 2 instead of hypercapnic is because hypercapnic respiratory failure almost always has concomitant hypoxia. So instead of admitting that they're two separate entities, just allowing some thought in regards to the fact that one entity is always present, in that the type 2 respiratory failure is slightly more advanced. And it's the same type of respiratory failure, but it's specifically a more advanced or more severe type. We talked a little bit about respiratory failure as a sign of end organ damage. Um, and a key concept to understand about end organ damage is that they can be entities that are secondary or primary. And this basically means that you can have an AKI from hypovolemia, that's a regular AKI, or you can have an AKI due to infection. And both are signs of end organ damage, but one entity is specifically related to kidney function and kidney recovery, but the other is also assuming that there's a separate entity at play that needs to be treated separately. So respiratory failure is a little bit important in the fact that the treatment doesn't usually change whether or not it's primarily or secondarily related to a disease state. But the treatment is always supportive, but the treatment does differ depending on whether or not you're talking about type 2 or type 1 respiratory failure. Um, so basically, I think that my literature studies on the topic kind of reflected what my clinical practice had been in Tanzania, is that when we're talking about respiratory failure, we're talking a little bit about heavily resource settings. So low middle income countries and even places in sub-Saharan Africa where, Uganda, Rwanda, are trying to do more ICU, as well as places like Mozambique are trying to do more ICU um, studying. There is not a lot of data on respiratory failure for critically ill. We do know, though, that almost half of patients actually receive oxygen when they are admitted to ICU level settings, and that a lot of inpatient hospitalizations take place for patients who are critically ill. Um, in one Rwandan study, there was a suggestion that probably about 4% of ICU admissions had ARDS, which is a very classic pulmonary disorder that causes hypoxemia. ARDS is basically non-cardiogenic pulmonary edema with degrees of hypoxemia, and there's certain ways to grade it. But hypoxia is a cardinal symptom of it. And basically, of these patients, you know, only oxygenation was offered, and ventilation was not necessarily something that was always um, thought through. But the identification of the type of respiratory failure was not present in this Rwandan study, which is something that is a very key important point, because it's basically implying that of the patients who present with pulmonary distress and end organ damage, that the end organ damage wasn't completely evaluated, and that the classification wasn't actually appropriately managed. Um, and of that study, in the Rwandan study, the ARDS patients, 50% of them had mortality. So pretty high mortality. We're talking about a pretty sick cohort when we talk about patients with respiratory failure. And it's nobody's fault that respiratory failure isn't necessarily diagnosed. It's likely because of the absence of blood gas, but it's also maybe slightly also due to the absence of awareness. You do need a blood gas in order to diagnose respiratory failure. It's what differentiates it between that and respiratory distress. Respiratory distress is a clinical diagnosis. And usually in pediatrics, we talk a little bit about it being either mild, moderate, or severe. Usually respiratory distress works its way up. So the way I usually think about it is that the abdomen starts first, then the chest, then the upper portion of the torso or the neck. So you don't usually see, nasal flaring until very severe forms of respiratory distress. Tachypnea is almost always present in severe. It doesn't need to always be present in mild to moderate. And, things like diaphoresis, breathlessness, altered mental status, um, things like that can usually be seen in severe respiratory distress. Um, Patients can have respiratory distress without respiratory failure, but usually they're concomitant. Respiratory failure just implies basically that the body is not oxygenating and that the body is not ventilating. And this is a laboratory diagnosis. The reason why we're good at identifying hypoxemic respiratory failure is that it's generally pretty easy. You just need an oximeter in order to be able to diagnose it, because that's the clinical criteria. Um, However, usually, if you're talking about true diagnosis of hypoxemic respiratory failure, patients get arterial blood gases. Um, and if you're talking about hypercapnic respiratory failure, patients need at least a venous or an arterial blood gas in order to basically demonstrate that the patient's, sorry, this should actually be, I will edit that, um, that the patient's PCO2 is greater than 45 and a pH is lower than 7.35. Usually the clinical findings of hypoxemic respiratory failure can be subtle, but respiratory distress plus possible cyanosis, they can become encephalopathic. And then there can be other signs, other clinical signs of end organ damage, and we can talk a little bit about what that might look like. When patients become hypercapnic or they develop type 2 respiratory failure, they can become altered. They can develop asterixis from their metabolic encephalopathy. But they can also have refractory dyspnea and usually tachypnea, despite the fact that you're offering supplemental oxygenation. I used to see this a lot in the ICU at Celiani, the fact that patients were placed on oxygenation and still complaining of dyspnea. It usually means that what's happening is that they're becoming acidotic. Acidosis can in itself cause general fatigue. It can cause the sensation of dyspnea, tachypnea. It's usually a primary respiratory drive that causes us to actually breathe harder when we exercise, when we run, when we walk, anything like that. But it is a primary driver in terms of creating a respiratory drive. Patients will still feel tachypnic despite not getting enough oxygen because they're either acidotic or they're hypercapnic. That's just an important thing to consider if you don't have a blood gas. My recommendation is, that all hospitals should start moving towards that. But we'll talk a little bit more about kind of that recommendation. But coming back to it, if you don't have a blood gas, recognize that hypercapnic respiratory failure can cause tachypnea that's refractory to oxygenation. So each type of respiratory failure is different to treat. So the type, and when I talk about hypercapnic respiratory failure, we're going to talk about two, and I'll have a table for you later. And type 1 hypoxemic. We'll talk a little bit about hypoxemic. So first, hypoxemic respiratory failure, the correction of it is to just increase the fraction of inspired oxygen. That's usually what we do when we create a nasal cannula or a positive or a oxy mask. The treatment is generally pretty simple. The more oxygen you give to the patient, the more you're going to correct the oxygenation. If they continue to be hypoxic, though, usually what we offer patients in refractory cases, at least in the United States, is something called PEEP, which just basically means positive end expiratory pressure. Patients have physiologic PEEP. It's what keeps the airways open. Usually when you talk about hypoxemic respiratory failure, you're talking about certain conditions that can put the airways at susceptibility of collapse in what we call de-recruitment or VQ mismatch. And we'll talk a little bit about that in the next slide. But when we're talking about VQ mismatch, we want to make sure that we open the airways up. And by offering PEEP, it creates a little bit more improvement to the ventilated areas, thus, improving perfusion and allowing for better oxygenation. This is a completely different treatment strategy, though, than treating type 2 respiratory failure or hypercapnic respiratory failure. When you're talking about treating hypercapnic respiratory failure, really what's going on is that the patient's minute ventilation is the issue. Um, and the minute ventilation is just the tidal volume times the respiratory rate. It's something that's measured in liters. And so you can imagine that, a minute ventilation of liters per minute needs to be about 8 to 10 in a patient who is critically ill. And that just basically means that they're taking tidal volumes of about 516 times, if that math makes sense. Um, and in order to meet metabolic demand, minute ventilation can be higher. And it can be done one of two ways. You can introduce pressure through a mechanical circuit, i.e. intubation, or you can do it through non-invasive positive pressure ventilation. You need to be able to improve the minute ventilation, though, if you're going to talk about decreasing CO2 retention just by purely fixing oxygenation and increasing the FiO2 that we do in nasal cannula or in an oxy mask. You're not going to necessarily see any improvement to the minute ventilation. And we'll talk a little bit more about why that is an important thing. So, specifically about hypoxia, there are certain conditions that can cause hypoxia. Um, and um, we know what they are. They're things that were probably learned in medical school. We talk about perfusion to ventilation mismatch, hypoventilation. We talk about shunting, and we talk about diffusion limitation. Specifically, what's happening in the lung when you're sending blood to the lungs, you're focusing on oxygenation. In this bottom diagram, you can see that there's basically like a ventilation and perfusion balance. And this happens with all portions of the lung. The lung reacts, or the lung capillaries react a little bit differently than all the body's other capillaries, in the fact that when oxygen is present, the blood vessels dilate. So oxygen needs to be present in order to send blood. If there is no oxygen present, in the alveoli is not full of oxygen and not oxygenating the actual capillary, what happens is that you get basically VQ mismatch or basically a lack of blood sent. If you send that forces the blood to go elsewhere, and it forces the healthy lung to try to oxygenate more blood, which ultimately meets the limit. And this is what is basically causing VQ mismatch. So if you have unhealthy tissue within the lung and there's pneumonia or edema, what you're going to experience is you're going to experience basically the way I think about it is resource limitation in terms of trying to send the blood to the healthier lung parenchyma. If a healthy lung parenchyma can't compensate for the extra oxygenation, we start to develop hypoxia. And this is the most important thing and reason for hypoxia in clinical practice. And it's probably the most common. We see it in infection. We also see it in blood clots. The pathophysiology is a little bit different because the blood can't get to healthy portions of the lung. So instead, what ends up happening is that you're having perfusion limitation as opposed to ventilation limitation. But the result is the same. You get hypoxic because the blood can't oxygenate. You can also have episodes where, you hypoventilate, or you have decreased FiO2 if you climb Kilimanjaro or you expose yourself to heavy altitude. If that's the case, then what might end up happening is that you will have lower oxygenation, or in the case of hypoventilation, also decrease your minute ventilation and develop hypercapnia. Um, and or you can develop some severe forms of VQ mismatch where basically you're shunting away from spaces. This is usually reserved for cases like cardiac shunts, like VSD, ASDs that aren't treated, where you're having actual non-oxygenated blood shunting across the heart, bypassing the lungs. This is a little bit more, severe and seen less often than BQ mismatch. BQ mismatch just basically implies that there's a pathophysiology happening in the alveolus, and because of it, the blood flow is basically um, being shunted away or taken away elsewhere. Diffusion limitation basically implies that the membrane is not permeable, so oxygenation can't make it across the membrane for whatever reason. The patient has interstitial lung disease, or they have some other condition that's basically causing the membrane to thicken. I want you guys to all imagine, though, that in cases of severe VQ mismatch, or in cases of severe hypoventilation, what ends up happening is that if the ventilation can't occur, oxygenation is the first thing to go. So you're going to develop hypoxia because the oxygenation is being moved away from the blood. The blood isn't getting oxygenated. But ultimately, what can end up happening is that you indirectly get CO2 retention. And this is when patients start to get in trouble. If that happens, carbon dioxide basically has nowhere to go. And this diagram in the top right hopefully makes a little bit of sense. But if you have a lower oxygenation concentration, what will end up happening is that blood flow will basically be shunted away, and it will inevitably go to more ventilated areas of the lung. Um, but the lung can only get rid of CO2 at a certain rate. And if it seems to be that the lung areas that are not getting perfused are not also getting ventilated. Um, Oxygenation is the first thing to go, but carbon dioxide is a close second. And so what ends up happening is that these patients develop an acute respiratory acidosis. They develop hypercapnic respiratory failure or type 2 respiratory failure. And especially in patients who have, obstructive pulmonary disease where they can't ventilate at higher areas of the lung, they develop wheezing. Um, then these patients can inevitably retain CO2 and develop a tricky situation like the patient that we talked about in the initial case. Um, so when hypoxemic respiratory failure becomes severe, the carbon dioxide will retain. Minute ventilation will then subsequently be affected because the patient's respiratory rate can't compensate for the lack of tidal volume. And then the patient will develop hypercapnia. So when we talk about, you know, types of respiratory failure, we're really talking about severity. So when patients are hypoxic, they present usually with just type 1. And this is basically just a lung failure, is one way that people have said it. And this just basically implies that, you're not getting enough oxygen, but that you're able to ventilate. What happens though is that if you don't necessarily treat, or the patient has a delayed response to treatment, an example of this would be a patient who is on antibiotics for pneumonia. If they're medically frail and they're not having enough time, they're going to progress to hypercapnic respiratory failure or type 2 respiratory failure if their body can't compensate or heal from the infection fast enough. So you might see this happen just in front of your eyes. If you're treating a patient, you feel like they're adequate, but then their oxygen demand starts to go up and they start to become more critically ill. It just basically implies that, a couple things. Their alveolar ventilation isn't happening quite as good. They're starting to retain carbon dioxide. And, certain things can be treated differently. You can start giving them treatment for COPD. You can try to help their minute ventilation by making them breathe faster. Um, but ultimately, you need to give them a little bit more time. And the way that we give people more time in the United States is by non-invasive positive pressure ventilation, or mechanical ventilation if they're sick enough. And the reason why is because if you leave it alone, CO2 narcosis can occur. And it's an acute acidosis, and it's an acute retention of CO2. And if you have an episode of CO2 narcosis, there are multiple etiologies about why the brain reacts to carbon dioxide the way that it does. But the one thing that I want you to take away from it is that there's a very high mortality risk. This is kind of like the most severe form of end organ damage that occurs to the lung. It's where end organ damage to the lung can ultimately affect the brain, and create a paradoxical bradypnea. Um, Even in a study performed in Europe, 12% of patients who develop hypercapnic respiratory failure who get admitted to IC level settings still end up passing. So mortality is really high. If you don't have the opportunity to treat, I wouldn't necessarily go as far to say as mortality is 100%, but this is an extremely morbid condition. And like I said, the reason why we're talking about this is because it's a condition that isn't necessarily always readily available for treatment in sub-Saharan Africa. But the first part of actually recognizing why it's important is to recognize the condition when it occurs. Just a quick moment on hypoxia. Some things that may be obvious and may be known. Oximetry is not always completely reliable. There's a standard of error within an oximeter to about 2%. They become less reliable when you start dealing with more severe forms of hypoxia. They're essentially unreliable. Their number is unreliable once they're after 60, but once they're below 80, the standard error can even be as high as 5. Um, and it's a representation of physiology that's occurring distally. So it's not actually what the lungs are seeing. And so if you start oxygenating somebody, just expect the delay in oximetry for about 10 to 45 seconds. But if you're continuously oxygenating somebody, you would expect them to be able to actually respond within a minute at least of any intervention. There's also this concept in the United States called recruitment, basically meaning that the alveoli have collapsed. You're getting, poor ventilation to the area and that thus getting VQ mismatch. The perfused portions of the lungs aren't oxygenating. So in order to quote unquote recruit alveoli, we talk about PEEP. And there are things called PEEP respondent or PEEP dependent hypoxia. This is usually something that we talked a lot about when we were, treating COVID-19, as well as treating patients who have, non-cardiogenic pulmonary edema or ARDS. And I know you guys already know this. 92% usually is the actual target oxygenation. So, um, why are we talking about this? Respiratory failure is very complex. And when we talk about offering acute care solutions to patients who are critically ill, one thing that I really want to kind of reiterate and discuss is that when you find an abnormality, you need to try to kind of figure out whether or not the abnormality is the primary issue, the primary insult, or the secondary issue. I would say that, I'd spend most of my day, not most of my day, but a lot of my day, um, determining whether or not something is a primary insult or a secondary insult, or even if it's on a different level, completely incidental. Um, and if it's completely incidental, then it doesn't necessarily play into the patient's care quite as much. It's something that's chronic that should be followed, but it's not necessarily something that warrants hospitalization. But if you see a primary or secondary sign of end organ damage or end organ failure, then it usually prompts admission. You know, two signs or two organ systems that are usually taken out usually requires ICU admission, at least in the United States. Um, and and especially when the lungs are affected. The lungs and the brain, I think, are probably the two most important signs of end organ damage. And of note, respiratory failure is probably the last sign of end organ damage before cardiovascular or cardiopulmonary collapse and arrest. So if you're talking about a patient who's otherwise systemically ill, somebody who has healthy lungs, usually the lungs are kind of maybe the last to go. And they can be the last to go because respiratory failure will kill you very quickly if untreated. And we usually, a good example of this actually is trauma. In patients who develop trauma, they can get multiple end organ damage, they can get AKIs, they can get coagulopathies, they can get all of these types of end organ damage. Um, but pulmonary is usually the last one to go. They usually develop ARDS last in the setting of their trauma. End organ damage just basically implies that you're having inadequate perfusion, you're having hypoxemia, you're having inflammation, or you're having a condition that basically causes damage to any portions of the end organ. And the end organs are, very important systems that are at play. We're talking about the lungs, we're talking about the heart, talking about the kidneys, talking about the liver. We're talking about basically like the inflammatory cascade and the enzymes that mediate clotting, so hematological abnormalities. And then we're also talking about the central nervous system. I bolded pulmonary and central nervous system basically to kind of come back to what we were talking about, which is that those are probably the two most important systems. You can live with heart failure for a little while. Shock will kill you pretty quickly, but respiratory failure by far kills you very, very fast. And then if you have central nervous system depression, basically what happens is that you can't breathe and um, the the central apnea will kill you pretty quickly. This is why we offer mechanical ventilation to our patients, is because it can bridge to a potential cure as long as you're understanding, what the extent of the possible prognosis is. Um, how do we do that? We can use certain scores, things like SOFA too, but we can also just use our general doctor brains and create a differential based off of what comorbidities we think are at play. Um, I make a big deal in the emergency department about, things like CVCs, things like, CRPs, ESRs, because those don't usually change my treatment. I either do or do not think that the patient has infection. Renal function, liver enzymes, those things give us a good example about how bad the extent to the organ is, how extensive the damage is to the end organ, to the liver, to the kidneys, to the coagulation cascade, or to the brain. But ultimately, really what we want to end up doing is we want to treat the most important things first. And that's why I think a venous blood gas is something that every blood or every laboratory should be able to do. Now, it's a very particular assay, and I won't go necessarily into why blood gas are less readily available in Tanzania than they are CVCs or whatnot. But if you're talking about truly intervening in acute care, usually the tests that I find that change my management the quickest are lactic acid levels, venous blood gases, and EKGs. And that's just because what we're doing is we're trying to risk stratify end organ damage. My neurological exam will usually give me some clue about neurological end organ damage. But really what I'm doing with these tests is I'm risk stratifying the patient's um, possibility for, cardiopulmonary end organ damage, as well as basically trying to surmise what interventions need to happen quickly. When we talk a little bit about, what things actually change my management quickly, it's generally these bottom three tests rather than these top tests that are all included in the workup for end organ damage. But if you're talking about a patient who is critically ill, you want to understand their metabolic status first. And their metabolic status plays very, very intimately into their respiratory status, because the body is responsible for excreting acid through the lungs. And if you can't do that, you develop type 2 respiratory failure. So, um, this is just basically a quick slide on what I already mentioned. But testing can be helpful to prognosticate the patient. Hopefully, the areas that you become concerned about, the understanding about what end organ damage might be at play, Also comes from your physical exam, comes from your history taking, it comes from you talking to the patient or talking to the patient's parents, their family, whatever it might be. If you notice that you're concerned about possible extensive end organ damage, and there are multiple areas, then you're usually offering treatment that is supportive to the patient. But two forms of end organ damage should usually prompt your concern, and we know that respiratory failure is an end organ. So if you have respiratory failure at play, then that patient should ultimately go to the ICU, especially if there's another form of end organ damage at play. So, why do we do chest x-rays in these patients? Um, Chest x-rays are usually pretty important, mostly for, I think, honestly, evaluating for infection versus edema. Um, That might sound a little bit crass to simplify a pretty complicated test like a chest x-ray simply through that. But if you have a patient who's sick, who doesn't have any traumatic mechanisms, and you're not looking for fractures or pneumothorax, and you're not evaluating for like etiologies of chest pain like aortic dissection, or pulmonary embolism, and you're more clinically concerned, that they sound wet or that they have fluid in their lungs, then your primary concern should be, is this infection or is this fluid? And the reason why is because the treatment of those are obviously very different. But you also want to make sure that, the patient isn't necessarily dyspneic for non-pulmonary reasons. DKA can make you feel dyspneic. Central causes can make you feel dyspneic. Cardiac things can make you feel dyspneic. There are a lot of different, causes of dyspnea. Anemia can make you feel dyspneic. AKIs can make you feel dyspneic. There are a lot of different reasons why patients can feel dyspneic. And a chest x-ray is helpful to me if it shows pneumonia, if it shows pulmonary edema, or if it's negative. And if it's negative, then you kind of have to start going to look for why other reasons why that patient might be dyspneic. And you might even be more concerned about the patient who has a negative chest x-ray, because you have to broaden your differential. Start thinking about pulmonary embolism or start thinking about other metabolic etiologies. More importantly than the chest x-ray, which I think is something that we all know that needs to be ordered when we're talking about a patient who's presenting with respiratory distress or respiratory failure. We're talking a little bit more about blood gas interpretation. And blood gases aren't very readily available. I don't think I've ever seen anybody perform an ABG in Tanzania, possibly VBGs and CBGs, which is a capillary blood gas. But in order to know how to interpret it, it's a generally important test. And the reason why is because you can have different types of acidotic states. If the pH is low, generally, the patient is acidotic or acidemic. Um, and differentiating whether or not it is a metabolic acidosis, or respiratory acidosis is extremely important in the implications of care. Acidosis is extremely common. I would probably say that I see an acidotic patient, at least once every shift in the United States. It's something that we don't necessarily have a good understanding about what the prevalence is in sub-Saharan Africa because these tests are not readily available. But I will tell you that blood gases are extremely important in change my management because I need to know whether or not the etiology of disease is driven through metabolic illness or through respiratory illness. Um, and that's kind of all I'll say about that. Blood gas interpretation takes some getting used to, it takes some training, but ultimately, once it's kind of implemented into a hospital setting, and you get good at it, you can definitely see changes in patients' care. You can see more readily identifiable, like type 2 respiratory failure or hypercapnic respiratory failure being treated more appropriately. um, you know, Assuming that you have the abilities to actually treat hypercapnic respiratory failure. And we talked a little bit about how respiratory failure needs to be treated with ventilation in severe cases, especially when there's CO2 retention. So when we talk about that, there are different types of positive pressure ventilation. There's non-invasive and mechanical, which we're going to talk about on the next slide. But non-invasive positive pressure ventilation basically implies something like CPAP or BiPAP. There are these new things called high flow nasal cannula that we use in the United States that I don't think I have ever seen in Tanzania. Correct me if you have it at your hospital, but high flow basically just focuses on oxygenation, so we won't necessarily talk about that as much. Continuous, seen here, is basically just providing the patient with what we call an EPAP. It's providing PEEP, and it's basically going to correct isolated hypoxia. It's not something that we generally use in the United States outside of like pre-hospital care. So firefighters and paramedics carry this. But usually when we talk about like actually trying to correct hypercapnic or type 2 respiratory failure, we talk about using BiPAP. And BiPAP is bi-level positive pressure ventilation. What BiPAP does is BiPAP actually forces some air into the alveolus and creates a positive pressure, and it matches or syncs that pressure with the patient's respiratory rate. But it also provides a backup respiratory rate. And so what you're doing is you're changing the respiratory rate to be able to have the patient match. And it uses sensors in order to be able to tell when the patient takes a deep breath. And then it also provides a positive pressure when the patient takes a deep breath in order to basically improve their minute ventilation. And by improving their minute ventilation, you're going to help them clear the carbon dioxide, and you're going to help them clear their type 2 or hypercapnic respiratory failure. So this is, when appropriately used, can save numerous lives. It's been shown to affect the morbidity and mortality of COPD exacerbations that we see more commonly in the United States because of tobacco and smoking that happens here. But it can also save the life of patients with lower respiratory tract infections, patients with edema, or patients with critical lung conditions. If this fails, usually the kind of end all for the respiratory failure algorithm is to intubate and to mechanically ventilate. When you're talking about mechanical ventilation, you're talking about basically complete control over the patient's respiratory dynamics. One thing that I really want to kind of harp on is that, patients shouldn't necessarily be treated with BiPAP. I could say confidently that patients shouldn't be treated with BiPAP unless you have blood gas, um, blood gas analysis, in the ability to interpret it. However, I will say that BiPAP is usually kind of a non-invasive measure. So it's something that I would say, a patient won't necessarily not benefit from BiPAP. So if I was talking about order of operations, I would rather have somebody who knows how to use BiPAP than have blood gas. But I don't think that anybody should ever be intubated or mechanically ventilated if you don't have the ability to run blood gases. The reason why is because you can hurt people when you intubate them. The reason behind this is a little bit complicated, but you're basically implying that you understand what their minute ventilation is when you intubate them. Intubation requires paralysis, it requires sedation. It usually carries several risk factors to the patient, including the fact that you're going to basically take over their respiratory drive. So if they have an unmatched minute ventilation because they have metabolic acidosis, and they're producing carbon dioxide at a faster rate than you otherwise would expect them to, then their minute ventilation will be higher. And if their minute ventilation is higher and you intubate them, you're going to kill them. And the reason why is because you're not going to necessarily know that the minute ventilation is something that you need to match. So if you take their airway, you can adjust PEEP and FiO2 based off of pulse oximetry or oxygenation parameters, but you will have no idea what you're doing to their carbon dioxide. And their carbon dioxide needs to be titrated appropriately based off of blood gas analysis. Most vents allow you to take objective measurements, but nothing will ever replace a blood gas in terms of being able to measure where the carbon dioxide levels and the pH of the patient is in relation to what minute ventilation you're giving them. Hopefully that makes sense, but I hope it is very understood that ventilatory support or mechanical ventilation should not be offered to patients um, who are acutely ill um, without having a blood gas. Now, things do change if they're in the operating room, but usually what I would say is that anesthesiologists who intubate patients who are acutely ill also want a blood gas readily available or readily done to be able to allow them to make any adjustments to the vent. One thing that I think is relatively frustrating is that when patients are intubated in the emergency department, people think that the job is done, that the stressful part is over. Intubation is not a curative procedure. It's a bridge to mechanical ventilation. Mechanical ventilation is what fixes people. Intubation has never saved anybody's life. Um, Really in the absence of any airway compromise, I suppose. But anybody who's trained in intubation should also know how to mechanically ventilate a patient. I will tell you that I have focused a lot of my time trying to train residents on how to ventilate patients rather than intubate them because they generally know how to intubate somebody. It's not necessarily a very stressful procedure, but they tend to have that because we have respiratory therapists in the United States. We tend to, as ER doctors, think that you intubate somebody and then you just walk away. But that's not the right way to do things. The right way to do things is to recognize that if you do intubate somebody, that you're also assuming the responsibility to ventilate them. And ventilation is complex. I hope that's kind of understood from, how much we touched on today, but also how much we passed on today, as far as respiratory failure goes, as well as hypercapnia goes, as well as carbon dioxide physiology. Um, but recognize that early and unnecessary intubation has been shown to kill people, and you need to be readily available to actually mechanically ventilate a patient. You also need to know what their minute ventilation is in order to mechanically ventilate and intubate a patient. And it doesn't have to be an exact number, but it has to be an estimation that you think can meet the clinical practice, and it has to be something that you can actually track. And the gold standard to track and titrate a minute ventilation is based off of the patient's ability to excrete CO2. And that's done through a blood gas analysis. So there is an evolving technology in the United States called ECMO that I just wanted to quickly touch on. I don't know if people are talking about this in Tanzania. Um, uh, when President Magufuli had COVID. This is ultimately something that he was transferred out of the country for. He, I think, had veno-venous ECMO. There's two types of ECMO. There's veno-venous and veno-arterial. Veno-venous basically bypasses the lungs. It creates an artificial lung system. It doesn't necessarily improve dynamics to any other organ system. The uses usually for veno-venous are for respiratory failure or, refractory respiratory failure. We saw it sometimes in COVID. I think the things that I've seen it most helpful for are actually like patients who develop ARDS. Usually from pneumonias, and become clinically stable, but need a little bit more time for the lungs to heal. When you talk about VA ECMO or veno-arterial ECMO, it's a very complicated circuit, but it usually requires basically like full cardiac or for full cardiopulmonary bypass. So you both oxygenating the patient as well as including their cardiac function. Um, and sorry, I say oxygenate, but also ventilate. You're improving ventilation as well as oxygenation in both of these circuits. They're both helping with ventilation and oxygenation. But VA ECMO basically bypasses the heart, which is like the big difference. So if you start seeing this in Tanzania or in Mozambique or wherever, it's out there. Um, so the case that we talked about initially, the patient had respiratory failure. They went from type 1 respiratory failure to CO2 retention and developed type 2 respiratory failure. When they developed type 2 respiratory failure, they developed a paradoxical bradypnea because of CO2 narcosis. And they started retaining carbon dioxide to create, acute severe respiratory acidosis. When you get acidotic, we didn't really talk about this, but your blood vessels start to dilate and you develop kind of a vasodilatory shock or distributive shock state, which ultimately causes, cardiopulmonary collapse and death. Um, so mechanically mechanically ventilating this patient would have at least bought her some time. She had some metastatic disease that was probably not going to necessarily respond to treatment, but it would have at least saved her from this condition. Um, in the United States, usually the conversations that I have with patients who have a bad prognosis is, this line, which I don't necessarily know if it translates to Tanzanian culture or not, but I usually suggest to patients' families, we can offer a therapy that might hurt or, save her. And it might not necessarily completely save her life, but it will buy her time. And if it does work, then it could potentially, be curative. And so, I understand that there are cultural difficulties trying to have conversations like this in Tanzania, and you don't necessarily want to imply that an intervention couldn't work, especially to family, because they might think that, that could potentially yield bad outcomes or bad juju. But um, it's a conversation that's worth having, at least trying, if you can, in order to basically, understand the family's expectations of care. It's called shared decision making is usually what I call that. So um this is a pretty easy summary. We talked a lot about end organ damage. We talked a lot about type 1 and type 2 respiratory failure. Remember that there are two categories and that they both kind of exist on a spectrum as relates to like lower respiratory tract infections, edema, things that, can cause respiratory failure. Remember what the minute ventilation is. Remember that the respiratory rate is a very important vital sign, but it's also tied, excuse me, it's also tied very, very closely to tidal volume, and tidal volume plays an intricate role in both minute ventilation, but also respiratory rate, as both of them are tied together. So that's kind of all I have for today. I learned recently from my wife about the MUHAS emergency medicine lecture series. I don't know if you guys have heard about this. There's a link. I'll make sure to get these slides on the KOPI website here shortly. Everything else from our prior lectures is uploaded to. I used Open Evidence for this. I don't know if you guys know much about Open Evidence, but it's an AI app that should be readily available to you guys. It's something that has partnered with JAMA and the New England Journal of Medicine, um, as well as, there are other like end organ damage scores on MD-Calc. Our next talk, you guys have expressed an interest in sepsis, so we'll talk a little bit about infection in the medicine that pertains to that. And I'm looking forward to it. I will put this video on YouTube later today. And I'll make sure that you guys, get the slide so that you can see it. Does anybody have any issues with getting the slides? You can use the chat. Speak up now if that's the case. All right. Any questions for today? You can also follow up on WhatsApp if there are things that I could maybe explain a little bit better. I know I talk very fast and my English is hard to understand sometimes, but hopefully the lectures helped a little bit and hopefully you understand a little bit about the importance of blood gas analysis. Okay. All right, Wada Clary, thank you for joining us. I'm gonna stop recording and we will end today and let you guys go on with your day.